Hey, Assalamu alaikum everyone. My name is Samra Mirza and I'm a third year medical student. So today we're going to be covering pathology practice questions. Most of these are representative of your course as well as any questions the doctors might focus on asking. So I hope they benefit you. So, okay, we're just gonna get straight into it, I guess. So these are all the topics that you have for your midterm, and inshallah, there's sufficient questions for all of them. And there is a memory. Okay, so you'll just have to answer on your own for the questions. Okay, 1, 2, 3, let's go.
Should I read?
Oh yeah, sorry. I was just gonna leave it silent, but it's okay. Yeah, you can read for sure.
All right. A 60-year-old male, a man with chronic cystitis, complains of urinary frequency and felt discomfort. Digital rectal examination is unremarkable. Biopsy of the bladder mucosa reveals foci of glandular epithelium and chronic inflammatory cells. No cytologic signs of atypia or malignancy are observed. Which of the following terms best describe the morphologic response to chronic injury in this patient?
What do you think the answer is?
Could it be metaplasia, since there would be glandular epithelium in somewhere that's not usually found?
Yes, you're very, very correct. It is metaplasia. So this is the explanation, and we can definitely come back to this. But okay, this is technically from your slides, and it's also from a summary. Normally in the bladder, you'd have transitional epithelium like this, and then you would have metaplasia as well as glandular cells forming. And sometimes in schistosoma, which is like an infection, you would have this, like these cells forming here, which you'll see when you come to them. But essentially, yeah, you're having glandular epithelium where it's not supposed to be, because you're again just supposed to have transitional epithelium. And squamous metaplasia is one of the forms of it, but it's not the one here. Does that make sense? No.
Yes.
Okay, yeah, this is just another example that I want to keep here with us because this is from the slides. So with Dr. Uban, what he usually does is he won't always give very long questions. His questions can be very, very simple, very straightforward, and sometimes he can just show pictures and like he could just show like this from here to here, and you can ask what happened, like is this metaplasia, is this hyperplasia, and whatnot. And so you can just answer it like that. You won't usually get a very long case when it comes to Dr. Uban. So this is just an example of what the question's based from. Okay, moving forward. I guess I'll read because I don't want to force you to read. So, a 32-year-old man experiences heartburn and gastric reflux after eating a large meal. After many months of symptoms, he undergoes upper gastrointestinal endoscopy, and a biopsy specimen of the esophageal epithelium showed that the normal squamous cells of the esophagus were replaced by a different type of cell, as shown. Which of the following pathological changes seen in the figure has most likely occurred? So, this is your picture. I can zoom in if you want. And yeah, these are your options.
I can rule out everything but A and C.
Okay,
It's
and
it's a metaplasia.
for sure.
Uh, but but now the weird thing about it is how will يعني what is the difference if I say columnar metaplasia and squamous metaplasia?
Okay, so here you would come back to, oh, you can actually get quite a bit of it from the question itself. So, it shows of the esophageal epithelium showed that the normal squamous cells of the esophagus were replaced by a different type of cell as shown. So, squamous metaplasia would just mean that a cell changed to squamous type cells, while columnar epithelial metaplasia would mean that they changed to columnar cells. So now what do you think the answer is?
It's C.
Yeah. So the esophagus' normal lining is just squamous cells, and when you have like acid reflux for a chronic period of time, you would end up having columnar epithelial metaplasia. Do you know what condition this could lead to?
Uh, can this lead to GERD, gastroesophageal reflux disease?
For sure. And it can also lead to Barrett's esophagus, a type of
Yes.
cancer. Yeah. Okay. So this is what it looks like. This is the normal squamous epithelium. And here you can see that if you zoom in, it's a really horrible picture. You have to go back to your slides to see it properly. But you can kind of very vaguely make out columnar cells if you really squint. Okay, good. Next question. A 47-year-old man with a history of heavy smoking complains of chronic cough. A coin lesion is discovered in his right upper lobe on chest X-ray. Bronchoscopy and biopsy failed to identify a mass, but the bronchial mucosa displays squamous metaplasia. What is the most likely outcome of this morphological adaptation if the patient stops smoking?
I would say it would revert back to normal.
Yes, very, very correct. That's very good. Okay, and why would you say that it's not going to lead to malignant transformation?
Since the patient stopped smoking, so it will cause the adaptation to reverse.
Yes, very correct. This is from, okay, this slide, it's from this master patho summary that we used in our batch, and I'm definitely going to send this after the end of the PAL session because it's very, very helpful for last minute cramming and revision. So essentially, metaplasia is still reversible, while dysplasia is the one that can like directly lead to malignant transformation. That's just like recall, I guess. Pretty simple. Okay, now this is more similar to the type of question that Dr. Oban might give you. One line, very simple, straightforward. So which of the following disorders is an example of metaplasia?
I would say squamous epithelium in the main stem bronchus.
Okay, facts. You're very, very correct. Good job. I'm clapping, but you can't tell that obviously. Okay, so, okay, last question for cellular adaptations. Which of the following is least likely to be associated with cancer development?
Uh, I would say hyperplasia.
Mhm. Ooh,
Wait,
I think this,
why
oh
would
yeah, this question has a typo. It should be most likely. I'm sorry.
it should be hyperplasia, I think, right?
For least likely, it would be hyperplasia for sure. I agree. Okay, yeah, this is a type.
Because yeah, because I think dysplasia would be at the end of neoplasia.
Yes, it very much is on the cycle of like reversible to irreversible injury. Dysplasia is at the very, very end, and it's like irreversible injury after which you would very likely develop cancer. Yeah, I'll fix this and send the correct version soon. Thank you so much. Okay. Okay, now we're moving on to the new topic, cell injury. This is going quite fast. In an experiment, cells are subjected to radiant energy in the form of X-rays. This results in cell injury caused by hydrolysis of water. Which of the following cellular enzymes protects the cells from this type of injury? What do you think?
Mm. Hydrolysis of water, can it be peroxidase?
Mm-hmm. Yes, yes, very right. It is peroxidase. Um, what's it called? And the rest of these enzymes obviously don't apply, and you can definitely read the explanation for this to further deduce. And then this is just again a little summary of the enzymes that really help. So yeah, so glutathione peroxidase is the one that's used here, and keep note of this because it might show up in a later question as well. Yeah. Okay. A 54-year-old man experienced onset of severe substernal chest pain over 3 hours. An ECG showed changes consistent with an acute myocardial infarction. After thrombolytic therapy with tissue plasminogen activator, TPA, his serum creatinine kinase level increased. And just to like give an idea, CK level increasing just means again myocardial injury. Which of the following events most likely occurred after TPA therapy?
Can it be reperfusion injury?
Very correct. Do you wanna deduce why it couldn't be any of the others?
I would say since tissue plasminogen activator would cause antithrombosis, so there would be no more blood clot. So due to that, there will be return of blood back to its regular. So that might cause reperfusion.
Yes. Very good job. Thank you. That's a really, really good explanation. Thank you. Okay. And this is again just a summary. Ischemia reperfusion injury or reperfusion injury almost always is like linked to MI and stroke. So it's like a keyword. Like whenever you see stroke and MI and they are asking about the type of injury, you can almost immediately deduce it to reperfusion injury in treatment. Okay, now this one. What is the reason for nuclear clumping in reversible cell injury?
Can it be intracellular pH decrease?
Yes, very correct. Again, um, oh, there's an explanation slide after the next question. Yeah. Okay. What is the first thing that happens after cell injury?
After cell injury, first there will be loss of cell function, then ultrastructural changes, then light microscopic, then gross morphologic. So it would
Perfect.
be A.
Yeah, very perfect. Very, very good job. And yeah, this is the slide that covers it. You would obviously have decrease in cell function at the start, and then slowly you would have ultrastructural, then light, and then gross morphological. This is just again a slide to revise all of the features of each type of cell injury. Again, a Dr. Uban could just show a picture of something and ask you what type of injury is going on, is it reversible, irreversible, or what kind of feature would you see in this? So again, memorizing pictures is almost always really, really good, especially for patho. And yeah, Dr. Uban's questions are very simple, inshallah, so it should be good. Okay. In an experiment, metabolically active cells are subjected to radiant energy in the form of X-rays. This results in cell injury caused by hydrolysis of water. Which of the following intercellular enzymes helps to protect the cells from this type of injury? I feel like this might be a repeat, but yeah,
Yeah,
continue.
it's repeated. It's a glutathione peroxidase.
Yeah, it is. Very nice. Good job. Okay, we're moving really fast. Now we're going to go to cell death. A 68-year-old woman suddenly lost consciousness. On awakening, 1 hour later, she could not speak or move her right arm and leg. 2 months later, a HET CT scan showed a large cystic area in the left parietal lobe. Which of the following pathological processes has most likely occurred in the brain?
All right. So since it's the brain, I can just say it's liquefactive.
Yeah, that's exactly the way to think about this. You see brain, you think liquefactive. That is very, very correct. Um, Yeah, so here is just an explanation. I think this is good to read at this point. Fat necrosis is usually seen in breast and pancreatic tissues. These are like keywords. Remember them always. Fat with breast and pancreatic. Coagulative is ischemia, usually for solid organs besides the brain. Apoptosis is for single cells. It's not something that's gross. And karyolysis refers to the nuclei of the cell. It's more microscopic than macroscopic. Okay, a 63-year-old man has a 2-year history of worsening congestive heart failure. An echocardiogram shows mitral valve stenosis with left atrial dilation. A mural thrombosis is present in the left atrium. 1 month later, he experiences left flank pain and notes hematuria. Laboratory testing shows an elevated serum AST. The representative microscopic appearance of the lesion is shown in the figure. Ooh. Which of the following patterns of tissue necrosis is most likely to be present in this man? Let me see where the picture is for this one, actually. 1 second.
Hold on. Could it be fat since AST would have something with the liver?
Mm-hmm. Very correct.
So I'm
Inshallah.
thinking. So
Mm-hmm.
yeah, I'm thinking fat since ASC is involved. So as soon as I saw AC is elevated, there is something wrong with the liver. So I'm thinking of fat since coagulative.
I get your what's it called? Understanding. So essentially in this case, AST, just give me 1 second to get the picture as well, because I think the picture would definitely help with this. Just a second. I'll show. Okay. So, okay, this is the picture that they were trying to show. Um, okay, so this is a type of picture they're trying to show. Now, based on this picture and what you know from your lecture, would you still call it a fat necrosis?
No, no, this would be coagulative since I can see it's firm.
Mm-hmm.
Yeah, I can see.
Yeah.
Yeah, like I can see the description of coagulative necrosis.
Mm-hmm. And okay, 1 second, sorry. So
But
here,
like,
um, yeah, here, so this is actually a picture of it's like from the kidney, it's a microscopic picture of the kidney, and they're trying to show like the renal tubules and the glomerulus, but it's obviously very messed up, and it's because, okay, so they had mitral, this is quite, what's it called? Like you'd have to think a lot more, even though with Dr. Ben you don't have these type of questions, but essentially he had mitral valve stenosis and left atrial dilation. He was like prone to developing a thrombus that would travel, like he was prone to developing a thrombus that could travel and block some artery. And that's essentially what happened and it happened in his kidney. So here, and it went to his kidney and it caused like a block, what to call it, a blockage in his renal artery, and that led to like necrosis, but coagulative necrosis of his yeah, kidney. Yeah. Does that make sense? So
yeah, that made
we
sense.
would rule out caseous necrosis because that is usually not seen with this type of presentation. And also the picture obviously makes it clear that that's not caseous necrosis. Fat necrosis, as we said, does not match the picture, which is not in the slide. And gangrenous necrosis is always limb related, so it's never here. And liquefactive is mostly for the brain. I'll definitely put the picture back in. Okay, for this one, a 59-year-old female alcoholic is brought to the emergency room with a fever and foul-smelling breath. The patient subsequently develops acute bronchopneumonia and dies of respiratory insufficiency. A pulmonary abscess is identified at autopsy, as shown in the image. Histological examination of the wall of this lesion would most likely demonstrate which of the following pathological changes.
Can it be liquefactive since there would be an abscess?
Mm-hmm. Okay, let's see. You are very correct. And yeah, liquefactive necrosis is always associated with abscess as well as brain-related things. Okay. Ooh. Anyway, and then an experiment introduces a knockout gene mutation into a cell line. The frequency of shrunken cells with chromatin clumping and cytoplasmic blebbing is increased compared with a cell line without the mutation. Overall survival of the mutant cell line is reduced. Which of the following genes is most likely to be affected by this mutation?
So they are asking for the pro-apoptotic, right?
Hmm. They're asking in this case for, I think anti because, yeah, they're asking for like which was going to be affected. Uh,
Oh, so they're asking about which of these would be yani, the anti-apoptotic.
yeah, that are going to be
So
affected by this condition.
it's B, I think,
Yes, very correct. BCL2, and what's it called? Bax here would be
is
pro-apoptotic.
pro-apoptotic.
Yes, very correct. The question is worded differently again, but again, if you can solve these questions, then inshallah, Dr. Advance should be a piece of cake. And then this is again just another summary of this. Okay, this figure illustrates. Okay, yeah, this I removed the figure because I didn't think it was similar to the other one. Actually, I'll add that again. This figure illustrates a microscopic appearance of the heart of a 56-year-old man who died after a 24-hour hospitalization of severe crushing chest pain, complicated by hypertension and pulmonary edema. The type of necrosis shown is best described as, even just reading the description, what would you think it is?
Coagulative.
Yeah, severe crushing chest pain as MI. I'll add the pictures again. Yeah, coagulative is related to MI, which is what they described here. Okay, and yeah, this is a picture of the norm of sorry, a picture of it from our lecture. So, this is the necrosis. Obviously, on gross, you would see it this way, and then okay, Don't look at the arrows because some of them have been misplaced, but essentially, here you would see the vacuolated myocytes. So they've been empty from the inside, and here are the infarct myocytes. They've lost some of their shape, obviously, and they've lost any characteristic feature that would have marked them as cardiac cells, as you could see here, with the nuclei and the what's it called, striations. Make sense?
Yes.
Okay, so okay, now this is the type of question that Dr. Uban would give. Which of the following disorders is an example of coagulative necrosis?
Okay, I can say that B, D are out,
Mm-hmm.
and I guess I would say it's E since it's mentioning embolus.
Yes, very correct. And this is something, this is a question from a hidden resource. You can think of that as you will. Okay, now this from here, I'm going to just do a very quick like a revision of certain things that I want everyone to remember for cell death. So starting with like the differences between necrosis and apoptosis, this comes under both cell death as well as cell injury. Obviously, starting off with apoptosis, it's more controlled, and it's instead of like spreading out, apoptosis just like leads to shrinkage, so you're getting smaller. It's very contained. And nuclei, they fragment, and that's just the keyword, fragmentation. And with apoptosis, you never have inflammation. Like it's a very controlled process and it's usually very normal as well. But while we talk about necrosis, necrosis is going to get big. It's going to get swollen and it's going to get messy. These three words are key for necrosis, so they're always good to remember. With necrosis, what's it called? They're going to release all their internal contents into the surrounding cells, and that might lead to frequent inflammation as the body's immune system reacts to this. And necrosis is always pathological, while apoptosis is often physiological, but can sometimes, very rarely, be pathological. That's just a revision of certain features, and then this is a revision of pictures. So pretty much what the heart this is pretty much what the heart's coagulation necrosis picture looked like for the question previous. And this is them trying to compare it to this picture, which shows like a greater deal of it. And this is coagulation necrosis. Is this much clear for coagulation necrosis, like the idea of it? These are just pictures you should always memorize. And when you see the exam with your eyes closed, you can very easily put coagulation necrosis. Okay, then moving on, liquefactive necrosis. Now, liquefactive, as we mentioned, is for the brain and it's also for abscesses. So I don't know if this picture shows it very clearly, but abscess is just like pus-filled little bags inside the liver, and you'd be able to see them in a better picture. And then this is the a gross picture of it as well as this. This is the entire liquefactive necrosis here. And then we have caseous necrosis, which is often described to be cheese-like. So it's usually seen in like long-term infections with tuberculosis. And a key word for caseous necrosis, it's almost always associated with Langerhans giant cell, which has this horseshoe appearance right here. And these pictures, again, they can always bring these pictures here. Okay. Um, yeah. And then we have fat necrosis, which is very distinct. You would have these white areas, and you can almost immediately tell that it's fat necrosis from those. And they're usually associated with the pancreas. Then we have fibrinoid necrosis, and you can see it here. Again, these are just pictures of memorization, and yeah. Again, his questions would be very simple. And then you have apoptosis, and this is a feature of apoptosis. You would see councilmen bodies. I'm again not pretty sure of this arrow, but yeah, you should refer to your slides for the pictures of apoptosis and anything else. With that, we are done with cellular adaptation, cell injury, and cell death, and now we'll be coming to Dr. Abrar's lectures. That's inflammation onwards, and yeah, his questions are almost always from Robbins Pathology. So that's where the majority of the questions here are from. And yeah, even after this session, I would just recommend going back to Robbins Pathology, as well as watching Khalid Jamil's Patho crash course in case there's any confusion. So let's start. An 11-year-old child falls and cuts his hand. The wound becomes infected. Bacteria extend into the extracellular matrix around capillaries. In the inflammatory response to the infection, which of the following cells remove the bacteria?
Could it be macrophage?
Yeah, you're correct. You're very correct. In the cells in acute inflammation, usually the cells that are involved are neutrophils and macrophages for the killing in the end. And the rest of these are usually not involved in acute inflammation. Okay. A 53-year-old woman has had a high fever and cough productive of yellowish sputum for the past 2 days. Her vital signs include temperature of 37.8, pulse 103, respirations 25 per minute, and blood pressure 100 by 60. On auscultation of the chest, crackles are audible in both lung bases. A chest radiograph shows bilateral patchy pulmonary infiltrates. The microscopic appearance of her lung is shown in the figure. Figure's not available, I'm sorry. And which of the following inflammatory cells is most likely to be seen in greatly increased numbers in her sputum specimen?
So I guess I would say for the past 2 days.
Mm-hmm.
And I guess after these 48 hours, the number of macrophages would increase. But if they are just talking about the past 2 days, then it would be neutrophils.
Okay, yeah, that is a very good way to go about it. Yes. Okay, wait, this is a picture. Sorry. Here you go. Now look at this picture and then answer.
I, this is neutrophils. I can see the lobes.
Yeah, very correct. You can see the lobes here. So your final answer would be
The
yes, neutrophils. Yeah, sometimes the wording can be quite confusing with 2 days or with 3 days, whatever. But usually when things are yellowish, like that just means are like purulent, it's almost always dead neutrophils that are involved. So if you do get confused by the number of days, just remember yellow plus purulent neutrophils. Okay. A 6-year-old child has a history of recurrent infections with pyogenic bacteria, including Staphylococcus aureus and Streptococcus pneumonia. The infections are accompanied by neutrophilic leukocytosis. Microscopic examination of a biopsy specimen obtained from an area of soft tissue necrosis shows microbial organisms, but very few neutrophils. An analysis of neutrophil function shows a defect in rolling. This child's increased susceptibility to infection is most likely caused by a defect in which of the following molecules? What is mouth?
I can definitely say it's either selectins or integrants.
Okay, now think further and tell me which one would you choose from integrins or selectins?
So they said rolling, right?
Mm-hmm.
So that would be selectins.
Yeah, you're very correct. It is selectins. So, again, explanation is for reading, but here's also just the diagram and the summary. For rolling, you have silyl and E-selectin. So rolling is with selectin. Adhesion is integrin to ICAM, so I and I, and diapetasis is through the PCAM enzyme. And this is just a diagram for your revision. Yeah, you're very correct. Good job. Okay. In an experiment, bacteria are introduced into a perfused tissue preparation. Leukocytes leave the vasculature and migrate to the site of bacterial inoculation. The movement of these leukocytes is most likely to be mediated by which of the following substances?
Chemokines.
Yep, very, very good. Good job. That's very good. Okay, and yeah, okay, we can move to the next question. A 25-year-old woman develops a sore, red, hot, swollen knee. She has no history of trauma and no familial history of joint disease. Fluid aspirated from the joint space shows an abundance of segmented neutrophils. Transendothelial migration of acute inflammatory cells into this patient's joint space was mediated primarily by which of the following families of proteins?
So they're talking about diapetasis,
Mm-hmm.
or are they
It's
just
just the
talking about
overall process of migration of these cells.
overall process? So integrants would be involved.
Yeah. Yep. Very, very correct. And you don't need to worry about the diagnosis. And with that, we come to this is just some cardinal signs of inflammation, which I think should go with this slide as well. So you have heat, redness, swelling, pain, and loss of function. It's also very important to remember the other names, which language it is, but you have tumor, you have rubor, you have Calor, and you have Doler. So remember those names for cardinal signs of inflammation. And then we come into chemical mediators. So a woman who is allergic to cats visits a neighbor who has several cats. During the visit, she inhales cat dander, and within minutes, she develops nasal congestion with abundant nasal secretions. Which of the following substances is most likely to produce these findings?
Allergic reaction to histamine.
Histamine, yeah, very, very correct. Good job. No, you don't even have to worry about all of this. You see allergic, you think histamine. In an experiment, T lymphocytes from peripheral blood are placed in a medium that preserves their function. The lymphocytes are activated by contact with antigen and incubated for 4 hours. The supernatant fluid is collected and found to contain a substance that is a major stimulator of monocytes and macrophages. Which of the following substances released into this fluid medium is most likely to stimulate macrophages?
As soon as I saw a major stimulator of monocytes and macrophage, it would be interferon gamma.
Yes, very, very correct. It's a very important chemical mediator, and um, if there's anything to take away from the chemical mediator lecture, it's definitely interferon gamma and its relation to monocytes and macrophages. This table is just, again, a summary of all the chemical mediators in relation to their function. So just go over this in your own time. A 41-year-old man has had a severe headache for the past 2 days. On examination, his temperature is 39.2 degrees Celsius. A lumbar puncture is performed, and the cerebrospinal fluid obtained has a WBC count of 910 millimeter cubed, with 94% neutrophils and 6% lymphocytes. Which of the following substance is the most likely mediator for the fever observed in this man?
Tissue necrosis factor.
Mm-hmm. Very, very correct. Okay. A 95-year-old woman touches a pot of boiling water. Within 2 hours, she has marked erythema of the skin of the fingers of her hand, and small blisters appear on the finger pads. This has led to which of the following inflammatory responses?
Uh, so would this be something similar to pus or not really?
Not really. It's blisters, so it's a degree lower than pus, I would say.
Could this be purulent or serous?
You're on the right path. So which would you choose, purulent or serous?
I would probably choose serous.
You're very right. Yeah, it is serious. Um, so for this, there's just some keywords and some scenarios to remember. Serious inflammation. There's some pictures in your slides as well of like blisters on a person's finger. Also memorize the histopathological slide of that. But essentially, blisters are always related with serious inflammation. Purulent inflammation, yes, there's pus involved or even abscesses involved, but then they're usually still a degree higher. They're still a bit more severe than serous inflammation. Okay, very good. A 24-year old sexually active woman has experienced lower abdominal pain for the past day. Her temperature is 37.9, and on palpation, the left lower abdomen is markedly tender. Laboratory findings include a total WBC count of that, and with 75% segmented neutrophils, 6% bands, 14% lymphocytes, and 5% monocytes. Laparotomy reveals a distended, fluid-filled, reddened left fallopian tube that is about to rupture. A left salpingectomy is performed. Which of the following is most likely to be seen on microscopic examination of the excised fallopian tube?
Could this be liquefactive?
Mm-hmm. It is liquefactive. Now, would you like to give your thought process behind this question?
I
How?
guess since there would be fluid filled, so there is uh, purulent inflammation, which has something to do with pus, if I am
Mhm.
correct.
Yeah.
So over time, if it persists, it might cause liquefactive necrosis.
Mm-hmm. That's good. That's very.
So yeah, that's my way of
Mhm.
thinking.
That's really good. And also, what's it called? The Langerhans cell would always be excluded unless it's a case of TB. Fibroblastic proliferation isn't mentioned here. This is something that comes later for healing. Squamous metaplasia has no role here because there's nothing about it here. And mononuclear infiltrates, they were They would not be involved for something like this because they had fluid-filled right and left fallopian tube. It's about to rupture. Mononuclear infiltrates would mostly be seen in a more chronic, non-specific chronic inflammation, if I'm correct. Okay, so yes, there's liquefactive necrosis, and you're very, very correct. Okay, which of the following morphological patterns of inflammation is shown below?
Um, okay, I think this would be. I don't think. Wait, hold on. Can it be A?
A, hmm, interesting. What makes you think of it being as A?
Hold on, because I have a feeling that this would be a picture of a lung. I'm not sure.
Hmm. Interesting. Um, well, it isn't A, but look at the gross picture as well. And what do you see on this? You are somewhat correct about it possibly being the lung, but it's not granulomatous inflammation. So take a closer look at the what's it called, the gross picture, and what do you think you see? What are the arrows pointing at in this one?
I think this is gray or yellow point.
Yeah, the yellow points.
Could this be suppressive?
Yes, so these are like little abscesses, like fluid-filled little pockets of pus, and that's suppurative or purulent inflammation, same name. Yeah. And okay, so now which type of inflammatory process is going on in this patient?
Okay, I can see Langhans joint cells, so D.
Yes, granulomatous inflammation, Langerhans giant cells right here. Very important picture. Also important to memorize the other pictures of giant cells besides Langerhans, so Teutons and the other ones. Okay, so now, a 50-year-old man has experienced mid-abdominal pain for several weeks. He is afebrile, and there is mild upper abdominal tenderness on palpation, and bowel sounds are present. Stool is positive for occult blood. An upper gastrointestinal endoscopy is performed, and biopsy specimens are taken. The figure shows microscopic examination of a biopsy specimen of a duodenal lesion. Which of the following terms best describes this lesion? So look at the picture, and what do you think you see in the picture?
There is discontinuation of the epithelium,
Mm-hmm.
so it's ulceration.
Yeah, no, that's very correct, and that's the right thought process for sure. Okay. A 37-year-old man with AIDS is admitted to the hospital with a 3-week history of chest pain and shortness of breath. An X-ray film of the chest shows bilateral nodularities of the lungs. A CI-guided lung biopsy is shown in the image. The multinucleated cell in the center of this field is most likely derived from which of the following inflammatory cells?
Macrophages.
Mhm. Very correct. This is chronic inflammation. 3-week history. It's very much chronic now, and giant cells are always coming from the actions of macrophages. So very correct. Okay, a 37-year-old man has had mid-epigastric pain for the past 3 months. An upper gastrointestinal endoscopy shows a 2 centimeter, sharply demarcated, shallow ulceration of the gastric antrum. Microscopic examination of a biopsy from the ulcer base shows angiogenesis, fibrosis, and mononuclear cell infiltrates with lymphocytes, macrophages, and plasma cells. Which of the following term best describes this pathological process?
I would say chronic inflammation.
Mhm. Very correct. Okay. Um, okay. A 63-year-old man develops worsening congestive heart failure 2 weeks after an acute myocardial infarction. An echocardiogram shows a markedly decreased ejection fraction. He dies 1 day later. At autopsy, a section of the infarct shows that the necrotic myocardium has largely been replaced by capillaries, fibroblasts, and collagen. Various inflammatory cells are present. Which of the following inflammatory cell types in this lesion play the most important role in the healing process?
Can it be macrophages?
Yeah, macrophages again. So macrophages have the two types, M1 and M2. So um, M1 is for the inflammatory process, while M2 is more towards healing. Okay, an experiment isolates peripheral, I think this is the last question. Yeah, an experiment isolates peripheral blood cells into a culture medium that preserves their metabolic activity. An interferon gamma is added to this culture. The cells are incubated. Next, a cell-free supernatant from this culture is added to a second culture medium containing E. coli organisms. Which of the following cell types is the most likely source for observed bactericidal activity against E. coli?
Can it be macrophage since there would be interferon gamma?
Yeah, very correct. Some keywords here, and they're always good to observe. Interferon gamma, macrophages. You are very, very correct. That is it. And that is all the practice questions. So these questions were just to give like a general idea of what the doctors can bring and what kind of topics could be covered from your exam, so from your content, so what's more high yield. Again, I would just recommend go back to Robin's Pathology and just keep solving as many questions as you can for abroad and do past batch. And yeah, and you're going to be set, inshallah, for Patho. It's very easy compared to everything else. Yeah, and I'll share the master patho summary, which again is really, really good for cramming last minute. So yeah, I'll send that in as well. Thank you very much for this, and I hope you all the best. I wish